Hello, friends and colleagues, and welcome to episode 93 of Dermosphere, the podcast by dermatologists, for dermatologists, and for the dermatologically curious. I am one of your hosts. My name is Luke Johnson. I am a pediatric dermatologist and general dermatologist with the University of Utah. And you might expect me to introduce Michelle Tarbox right now. She's actually not here right now, but she'll be joining us later. But right now, we've got a special guest. This is future Dr. Eleonora Marcacci. Eleonora, thank you so much for joining us. Do you want to start by introducing yourself?
Sure. Thank you so much for having me. Super excited to be here. My name's Eleonora. I'm a third-year medical student at the University of Utah School of Medicine. And next year I'll be applying in dermatology. So super excited.
And we are super excited to have you not only today, but also you are a member of Team Dermosphere, one of the medical students who keeps various aspects of this show running along. Before we get into the topic of the day with you, however, we want to talk about the Hawaii Dermatology Seminar, still sponsoring the podcast. Thank you so much for that. It is the 45th annual Hawaii Dermatology Seminar that's coming up this upcoming February 19th through the 24th. You'll want to come because we'll be there. We're going to have a booth, and you can also join other colleagues in Honolulu, and you'll find advancements in psoriasis, hair, atopic dermatitis, facial rejuvenation, cutaneous malignancies, and more. They cover everything. If you register today, you can use the exclusive discount code DERMASPHERE, DERMA Sphere, to receive 40% off your pass. But that's only for a limited time, my friends. You won't want to miss this innovative event or the chance to come hang out with Michelle and I. And hopefully Eleonora. But
Woo!
I don't know how you're going to get there. Maybe you'll swim. Or maybe you'll take a space shuttle. So Eleonora approached me and asked to speak about this particular article, which I thought was so neat. It's out of the Dermatology Online Journal and is called Dermatologic Manifestations in Spaceflight. A review came out in 2018. Our authors include Carly Dunn and Ida Orengo. Eleonora, why this one?
I realize this article is a bit outside of the box from what we normally talk about on the podcast, but as an avid space fan who's also pretty hyped about Derm, I thought this was pretty interesting and cool and thought someone else out there might too.
Yeah, for sure. And I think you mentioned you're hoping to have aerospace be a part of your future career.
Absolutely.
How does one combine dermatology and aerospace in a career? Not that I'm
Well,
trying to snipe your future job or anything.
well, hopefully by going over this article, that can answer some of those questions for you.
All right. Well, why don't you get us started then?
Okay. So, here they did a nice review summarizing common skin changes induced by spaceflight, including previously reported skin conditions, and exploring the risk of skin cancer in this unique population. So, if you are ever curious about derm in space, sit back and put your feet up because this episode is for you.
And we cannot let this article slide without saying, Derm in space.
Woo! Perfect. I love it. So, interestingly, in space, the most commonly reported medical event is dermatologic in nature, with an estimated 1.12 skin rashes pre flight year compared to 0.044 cases per year on Earth. General skin changes in spaceflight include increases in dermal collagen as much as up to 143% following a 6-month mission, thinning of the epidermis down to 30 micrometers compared to normal epidermal thickness, which can range from 27 to 150 micrometers, and increased molting time of the cells from the strontium basale towards the strontium corneum. Shifts in microbiota of astronaut skin have also been reported, and the epidermal thinning has been thought to potentially expose the lower layers of the skin to low wavelength ultraviolet light radiation, and that has been postulated to put this population at an increased risk for skin cancer. However, if you think you might be traveling to space at some point in the near future, not to worry because these changes were found to be reversible after the astronauts returned to Earth. So you won't have a thin epidermis forever, which I find reassuring.
Yeah, especially if you're going to be in space, though I think the odds of me ever getting into space are astronomical.
But
Thanks. I keep interrupting you. You obviously have a flow going. Sorry, I'll be
Oh,
quiet
you're
now.
great. You're great. We love the interruptions. So dermatologic conditions related to spaceflight that have been described include atopic dermatitis, contact dermatitis, dry skin, psoriasis, skin cancer, urticaria in response to decompression sickness, and infectious etiologies. Regarding infections in space, astronauts have been shown to experience immune system dysregulation while in space, which is likely due to physiologic and psychologic stressors, microgravity, and radiation. One study found that astronauts have an increase in urinary excretion of cortisol and catecholamines, supporting increased stress as a possible etiology of immune system dysregulation. Along with hygiene constraints and close quarters, this may predispose astronauts to increased risk of infection. Microgravity has also been reported to induce changes in microorganism virulence, antibiotic resistance, and growth. The microgravity environment of the International Space Station has been demonstrated to increase bacterial growth, likely related to low shear stress and low turbulence, which is an analogous environment to sites of bacterial growth in the human body. Common infections include cellulitis, dermatophytosis, and herpes zoster reactivation. One study reported most of the notable events on board the International Space Station were prolonged rashes, followed by infectious disease, atypical allergies, and cold sores. Now, regarding skin cancer incidents in space travelers, one longitudinal study of 312 United States astronauts reported that there were 33 diagnoses of basal cell carcinoma and localized squamous cell carcinoma. This was a statistically significant threefold increase in prevalence in these cancers over a comparison study. However, the study noted that the astronauts spend a significant amount of time outdoors for their training, and therefore the contribution of time spent in space on the risk of developing skin cancers is difficult to determine. But hopefully, future studies will shed light on that as we continue exploring the final frontier. So there you go. That's Derm in space.
It's nothing I've really thought about much before, except when I watch the occasional science fiction show. It seems like the upshot of this article is that dermatologic issues are actually like a fairly common thing if somebody's going to develop something while they're on some kind of space mission, but usually they're pretty mild, like a little bit of eczema or some urticaria. There's this report of an astronaut who got irritant contact dermatitis from some kind of paste they were using to repair a portion of the craft, I guess. And those sound pretty mild and boring, but then I thought, wait a second, these people don't have access to the resources that we have here, and it costs an extreme amount of money to send up, an extra pound or an extra kilogram of material. So I started wondering, what resources do they actually have? Like, what's in their little first aid kits? Do they have like a 30-gram tube of triamcinolone, and that's all of the dermatologic treatments they have? Do you know the answer to stuff like that?
Well, that's a great question, Luke. And from what I could find, it seems that regarding their hygiene factors, they're pretty much limited to no rinse shampoos and soaps. Topical emollients are having to be minimized to the absolute just bare bones what they can manage to get by on. And otherwise, exactly like you said, they go up with whatever medications they have on board. And so preparing for these kinds of things ahead of time is going to be key to making sure people are safe with these derm conditions in space.
So I assume they get loaded up with all kinds of vaccines, like the zoster vaccine, for
Yes,
example.
definitely that one. Be a
And
good
if
one to get.
you are hoping to become an astronaut, it seems like you also better hope you don't have any chronic health conditions at all, because even something fairly simple like well controlled atopic dermatitis or well controlled asthma or whatever, like you might not have access to all the stuff that you need, or it might just be prohibitively expensive to send it up with you. So if that's somebody out there, then here's hoping for good health for you.
Sending good vibes.
All right. Well, it's fun to talk about these sorts of things that we don't normally talk about. You said you gave us a teaser at the beginning that this would shed some light on how you might include this in your future career. So, what are you thinking, Eleonora?
Well, I think skin's really cool because, well, actually, so I was a neuroscience major in college, and I remember one of our neurology professors once said that he thought the brain was really cool because it's the only organ that you can talk to that will talk back at you. I think the skin's really cool because it's the only organ you can see and that it's your interface with the world and with reality. So, kind of in the same way that A spacesuit is your interface with space, and we think about all these things that go into that. Your skin is almost like your spacesuit here on Earth, if you think about it. So I think considering the parameters in which skin can change when it's exposed to things like microgravity is super interesting. It might actually impact how we practice down here on Earth. But here's hoping.
Yeah, that's cool. I hadn't thought about that before. And I assume that this is more of a article of interest rather than something that impacts our daily clinical practice for most of our listeners. But who knows how things are going to go with Virgin Galactic and various commercial spacecraft on the horizon, so to speak. Maybe this will become more of an issue. Well, thanks for bringing it to our attention, Eleonora. Thanks for all you do for Dermosphere as well. I think that after this article, it's clear you are a rising star in dermatology. And
Ooh,
thanks again for joining us for Derm in Space.
thanks so much for having me.
Bye, Eleonora. No, now I'm lonely. Oh, look, it's Michelle. Hi, Michelle.
Hello, Luke.
You didn't get to introduce yourself earlier. Would you like to introduce yourself now that you've just walked into the digital room?
Of course. So it is nice to see everybody, or hear everybody, or virtually hear everybody today. This is Michelle Tarbox. I'm an associate professor of dermatology and dermatopathology at Texas Tech University Health Sciences Center in beautiful, sunny Lubbock, Texas.
And joining you is the Pimping Bell. Would you like to introduce the Pimping Bell?
So our pimping bell. What do we do this? What do we use that for, Luke?
We use the Pimping Bell to highlight especially testable or noteworthy content. So if you're a resident, you might watch out for questions about whatever we're ringing it on. If you're an attending, you might pimp your residence based on the Pimping Bell's recommendation.
Well, and actually, Luke, I had a discussion with my father, who's an ardent listener of our program just last night, about the fact that for the occasional layperson who does listen to the Dermosphere podcast, we maybe should explain what the pimping bell, what pimping is, because if you're a layperson who's not a sort of medically acquainted one, you might not understand what that means. Of course, we know pimping in the medical world is actually asking questions, usually done by an attending physician, and the practice originated in the 19th century, but was repopularized in 1987 after a publication about pimping at the bedside.
Yeah, now that your dad mentions it, maybe we should have come up with a different name. Maybe it should have been the Testable Bell or the Socratic Bell, because isn't it kind of like the Socratic method to ask
Oh,
questions?
we could call it Socrates. That would be cute.
Socrates, the Pimping Bell. You got to put a little like beard on it and stuff.
I'm 100% doing that.
Well, speaking of things we see in dermatology, Michelle, have you ever seen a patient with warts?
Oh my goodness, yes, lots and lots of them. Sometimes they're very difficult to treat.
But have you ever seen a patient with warts on the bottom of the foot?
Why, in fact, I have. In fact, sometimes those are the hardest warts to treat.
Indeed. So plantar warts, not plantar's warts, but plantar warts. So how do we treat them? Well, here's a systematic review about it. So this is out of the journal Dermatologic Therapy. It's called Topical Treatment for Plantar Warts, a systematic review. The authors are out of Madrid in Spain and include Sarah Garcia Oreja and Jose Luis Lazaro Martinez.
Very nicely done. I'm impressed.
So, a systematic review of treatments for plantar warts, 44 studies with about 2,800 patients. So, here is the upshot. The cure rates for various topical treatments for plantar warts in decreasing order of efficacy. The winner is a formulation containing cantharidin, podophyllin, and salicylic acid, which had a cure rate of 98%. This was over 5 studies with 250 patients treated with just 1 or 2 sessions of this stuff. Enticing. We might talk more about this one later. So again, 98% cure rate with that concoction. Number 2 was intralesional bleomycin with an 83% cure rate. We'll talk a little bit more about the details in a second. I'll just get through the winners here. Number 3 was photodynamic therapy or laser, 79% cure rate. They batched those two treatment options together. After that was topical antivirals with 72% cure rate. I guess that's like topical cidofovir gel, which you can get compounded in some places. Then intralesional immunotherapy with things like candida antigen or vitamin D with a 68% cure rate. Cryotherapy, not doing so hot with a 46% cure rate. Even worse than that was salicylic acid at 14%. And finally, duct tape with a 6% cure rate, perhaps representing a control arm or control foot. Maybe that's the percentage that just go away on their own anyways. So a few more details. This cantharidin, podophyllin, salicylic acid stuff was evaluated in 5 studies with 250 patients, pretty decent, with just 1 or 2 sessions curing them. Intralesional bleomycin with a 83% cure rate was evaluated in 7 studies with 350 patients. In 140 of those patients, it was delivered via a device called the Dermojet, I guess. You ever heard of the Dermojet, Michelle?
Is it like a mesotherapy device? It sounds kind of like one.
I assume it's what you and I will fly once this podcast becomes so popular that we can afford to buy our own private
Luke.
Dermojet.
Let me look it up. So the Dermojet, it's a needleless syringe, and it injects things by intradermic projection without the use of a needle.
So it just like shoots it really hard in there with air, I guess.
Yeah, I think it's an air canister thing. If it looks very much like an air canister.
And these people were cured, 83% of them anyway, in 1 to 5 sessions of bleomycin, again, Dermojet or intralesional, just old school injections over 6 to 24 weeks. Pretty good. I like bleomycin. Yeah. PDT or laser was evaluated in 8 articles with 240 patients, a mean follow-up of 36 weeks, a maximum of 7 sessions. Cure rate was 79%. Intralesional immunotherapy was evaluated in 5 studies. Remember, this was a 68% cure rate. 3 of those 5 studies were for vitamin D, and the others were for MMR and Candida. I don't have vitamin D or MMR. I'm not super impressed with the data, honestly, when I looked into it. But for Candida specifically, there was 1 study with 80 patients over 1 to 8 sessions with a cure rate of 65%. There was no comparison arm. By the way, you might remember that in episode 64, we discussed a trial of Candida antigen in common warts, not plantar warts, where Candida had a 63% complete cure rate versus 20% in the cryotherapy group. So I kind of like Candida antigen. Mm-hmm. Cryotherapy, with its mediocre 46% cure rate, was evaluated in 15 studies with 600 patients. The mean follow-up was 15 weeks. The number of sessions ranged from 1 to 12. Quite the range. And then salicylic acid, with its paltry 14% cure rate, was a 50% formulation, which is kind of hard to find. It was self-treatment. There was 1 randomized controlled trial with 230 patients up to 8 weeks, which might just not be enough time, honestly. And then this duct tape thing was 2 studies with 90 patients, and in 1 study, the duct tape just served as the control foot for comparing it to something else. So the authors of this study posit that the more effective treatments are more effective because they trigger a greater immune response, perhaps. There are a number of problems, including the heterogeneity of study design. So, for example, salicylic acid following people for 8 weeks versus PDT or laser following people for 36 weeks. Like, some people are just going to get better on their own if you give them an additional 26 weeks to see if it happens. And then if you treat them more frequently, of course, one assumes that they're more likely to get better. There are potentially different patient populations. These are articles from all over the place. Most of these studies were unblinded. It's probably hard to create things like a sham laser treatment, for example, but there's various potential biases. I tend to be skeptical of the treatments that use devices, for example. I figure the people who own the device kind of have a vested interest in sort of showing that it works, or some of them were probably sponsored by the device companies, like I suspect that Dermojet study, for example. Mm-hmm. And again, different numbers of treatments, different follow-up times. Some warts just go away on their own. So they say most of the studies are non-comparable. But still, I think it's helpful to have some kind of this basic idea here. The authors do suggest that future studies should also include cost-effectiveness data, which makes sense to me. Again, I'm looking at you, devices. And they cite 2 previous studies from 2012 and 2006 that analyzed cryotherapy versus salicylic acid and concluded that cryotherapy is more expensive and less effective than treatment with 50% salicylic acid just at home. I'll certainly buy more expensive because they have to keep coming in and we have to keep charging them destruction of benign lesion codes, which are surprisingly expensive, versus just prescribing them. I guess you have to prescribe this 50% salicylic acid because I think the strongest you can get over the counter is 40%, and having them do it at home. But this review found a cure rate much better for cryotherapy at 46%. Maybe it's an adherence thing. Who knows? But in general, this cantharidin, podophyllin, salicylic acid stuff, spoilers, Michelle's going to talk about it some more. But since I don't have that, the I have intralesional bleomycin in my clinic, and I think we've discussed it before. It's not something I actually learned to do in residency, probably a deficiency of my program.
Ah.
Well, some places just have it and some don't, so I think that's probably the issue.
It's often preference. So there's a lot of handholding required for bleomycin, and it is got some relatively strict regulatory constraints around it for appropriate reasons. It can be a potentially dangerous medication. So some people really are sort of devotees of the bleomycin, and other people have been burned or sclerosed, I suppose, one too many times to use it. But
Well, when I want to use it in clinic, I usually don't use it first line. It's usually like second or third line for something that's kind of recalcitrant. And I ask the MAs to please go get some bleomycin. They have to get the clinic manager and walk through 2 locked doors with combination locks and have 2 people put their thumbs on the thumb printers to open up the secret safe where the bleomycin is. And then they have to wear a full hazmat suit when they bring it into the clinic. It's not
you're
quite that
kidding, right?
extreme.
Okay.
They do. It is locked. It's in this locked
Someone,
box.
at first, I was like, okay, it's believable. And then you said hazmat suit, and I was like, nope, nope. This is a confabulation.
Well, it is in a little locked box, so they have to get the key, and then you have to wear special gloves, and you have to put it discard it in a special sharps container. But anyway, it's actually very straightforward and pretty effective. And then I also like Candida. Cryotherapy is acceptable, and otherwise it's kind of annoying. Some other factoids that came out of this article: 40% of the population is, quote, infected with HPV. 40% actually seemed like a low number to me. We've discussed in previous episode that probably we just have a ton of HPV living in our DNA due to evolution. And they say of which 7 to 12% of this 40% will develop a wart. The annual incidence of plantar warts is 14%, and 2% of the general population seeks medical care for warts annually. That's a lot of people.
Mm-hmm.
They say if a wart lasts for more than 2 years, it's called recalcitrant. Their definition of recalcitrant is a little different than mine. I guess I would call them recalcitrant if we've tried treating them with a few things and they haven't resolved. If they just sit there for 2 years, I don't know that I would call them recalcitrant.
Mm.
The HPV can remain dormant in the stratum basale for 12 months, and HPV sneakily evades the immune system by triggering T suppressor cells.
Hold on.
So, thank you. This article came to my attention thanks to a couple of my colleagues here. So thanks to Rick Sondheimer and C. David Hansen, who were looking for ways to treat warts. And what really stands out, aside from sort of bleomycin actually being pretty good, and we have it, is this cantharidin, podophyllin, salicylic acid stuff. So I'd never heard of it before, but Michelle, let me hear about it some more.
All right, so we are going to do a deep dive back into a little bit of history as well as into a journal most of us probably don't read, the Journal of the American Podiatric Medical Association. I'm trying to think of what their JAPMA? No, I don't know. I was trying to figure out how you would abbreviate that. So this article is actually from 2008, and it's entitled Application of Cantharidin and Podophyllotoxin for the Treatment of Plantar Warts. Chief authors are Ricardo Becerro de Bengoa Vallejo, who is a doctor of podiatric medicine and a PhD, and Antonio Saez Crespo, who is a PhD. And they were out of the Escuela Universitaria de Enfermería, Fisioterapia y Podología. I said that last part wrong. In Madrid. Very cool. And
also out of Madrid.
I know. So lots of Madrid people.
Maybe this is like the Madrid treatment. That's what we should call it. Yeah, give that patient the Madrid treatment.
They're going to get the Madrid treatment. That sounds like something they'd use as an abbreviation for something in The Sopranos, but I digress. So there's lots and lots of different ways to treat plantar warts. They're difficult to treat. Often, if there's a very long list of therapeutic options for a condition, that means none of them work terribly well. But this has a lot of promise. So they wanted to look at the safety and efficacy of a topical formulation of cantharidin, podophyllotoxin, and salicylic acid compounded in a collodion membrane, so kind of like wart peel is, in the treatment of plantar warts. This is a combination that's widely used in Europe, but really hasn't been described elsewhere, and they wanted to undertake an investigation about how to use it. They did a retrospective study of 144 patients with simple or mosaic plantar warts that were treated with this topical pharmacy compounded, what they call later in this paper, magistral solution. Magistral is a funny word. In the routine layperson usage, it just relates to somebody who's a master. So you could say it was a magistral performance, or there's a magistral ballad or something like that.
Oh, this is a magistral podcast.
Yeah, of course, especially because of you. You're quite the magistral of all of these things. And even bleomycin, because you use it now. Good job. So the magistral medication is a product that's made in the pharmacy specifically for a individual at the instruction of a physician. So if you give a prescription that's a unique compound or whatever to a pharmacy, that's a magistral prescription that's being made for your patient. So this contained that cantharidin 1%, podophyllotoxin 5%, and salicylic acid 30%. All of the patients, which were aged 8 to 52 years, were treated with their standard protocol, which is basically cleansing the area, debriding the keratin layer on top of the wart, applying the solution, allowing it to dry, and then putting on a dressing. After they did this treatment protocol, they had, out of the 144 patients, 92 who were being treated for the first time. They had 52 patients who had been previously treated, and none of those 52 previously treated patients had received more than one type of other treatment in the past. So these are relatively, if I can use the phrase here, virgin warts. So they haven't really been subjected to any attempted therapeutics, which may kind of indicate a slightly easier population of warts to treat. So it would be very interesting to see how this preparation behaved in patients with more recalcitrant warts. But in this patient population, this solution did very well. After 6 months, they had complete eradication of the plantar warts in 95.8% of their 144 patients. So 138 out of their 144 patients had complete eradication of the warts, that sounds almost too good to be true based off of my personal experience with warts, because they're very stubborn and difficult to clear, especially plantar warts.
Yeah, so much improvement after just one treatment.
Yeah, so 86.8% of their patients only had a single application. 13, which was 9%, needed 2 or more applications. They didn't have any significant adverse effects or complications. So they found that this was a safe and effective way to treat mosaic or simple plantar warts, and was a promising alternative treatment modality for plantar warts. So let's talk a little bit more about plantar warts. As you discussed, Luke, family is Papaviridae. At the time of publication of this article, it says there's more than 90 human papillomaviruses. Now there's more than 150. We just keep finding new ones. They're extremely prolific viruses that are very good at infecting humans. They are non-enveloped, double-stranded DNA viruses that have a circular genome, and it has 50 to 50 nanometer in diameter size, and they have an 8,000 base pair genome. The Gardasil vaccine is a combination of the viral capsids, so just the house that the virus lives in, none of the actual viral DNA, for the 9 HPV types 6 and 11, which cause genital warts, and then the high-risk types 16, 18, 31, 33, 45, 52, and 58.
Ding, ding. Yeah.
So there are different ways to divide up the family of human papillomavirus. They can be defined clinically according to where they like to infect the skin in 3 large groups: the cutaneous versions, the mucosal ones, and the indiscriminate ones that will affect mucosa or cutaneous sites. And then you can also talk about where they tend to infect the cells. Usually they're going to infect the germinative or basal layer cells, which allows them to perpetuate the infection throughout the epidermis. And they're able to do this because there are specific receptors for these viruses on those basal keratinocytes. Then the viruses, once they get into the cell, they adhere to the cell through those receptors. They undergo endocytosis, so the virus now penetrates into the cytoplasm and releases its genome into the cell nucleus, where then the viral DNA becomes amplified and infection is propagated throughout the epidermis. Once you get to the horny cell layer, there is no longer any DNA replication. So really, those are just dead bags full of viral genome that get shed into the environment and then are introduced into other people's skin or auto-inoculated into the same patient's skin through small fissures in the skin or mucosa, and can be transmitted by fomites such as towels or contaminated bathroom, shower stall floors, or I think the biologically engineered surface to transmit the human papillomavirus is a pool deck because it's abrasive and people's feet are wet on it. Lots and lots of treatment modalities exist, as dermatologists we're familiar with all of those. One of those things is cantharidin that we use. This is a crystalline anhydride of catharic acid, not cathartic acid, but catharic acid, which is the active principle of blister beetles, order Cleoptera, family Melioridae, which are common in Europe. There is evidence of them in historical literature as the Spanish fly, which was used actually as a aphrodisiac in small doses, but people had to be careful about the dosage because overdosage could lead to death. These are emerald green. You have a funny thing to say. Go ahead.
Well, I don't know if it's funny, but they say powdered Spanish fly was used by the Romans as the basis of philters because of its aphrodisiac character in small doses, but there's no citation there.
One of these people who wrote this article, clearly a vampire, has been alive since then, knows firsthand. So, anywho, they have high toxicity in small concentrations. So, if you have enough of a dose, you could get gastralgia, nausea, fever, vomiting. Higher doses can even irritate the renal epithelium, causing nephritis and death. And externally, it can be a vesicant. It acts by inhibiting the protein phosphatase 2A, an important enzyme in the metabolism of glycogen. And it's been used medicinally in China for over 2,000 years. And it was authorized as a bulk substance in 1997 and was available in the US since that time. It does have a good history of safety when it's applied by professionals. Podophyllotoxin is also used to treat plantar warts. It is cytotoxic and inhibits cell mitosis, interrupting the process of cell division. Its application is topical, contraindicated in patients who are allergic. Typically, your concentration is like an order of magnitude less than what they're using in the solution. So what you typically use topically is 0.5% solution. Here in this compounded prescription, it is a 5% concentration. Sorry. And so they talked about potentially using these treatments after other things had been attempted. Their patient population was fairly representative versus men versus women, but it was highly Caucasian. There weren't a lot of patients that had more diverse phototypes in this patient population. I think that they said it was like 98% Caucasian or something like that. So the generalizability of the study may need to be looked at in different patient populations. The fact that the cantharidin works by lysing the epidermal cells only and leaving the basal layer intact helps to prevent scarring, which I think is a nice piece of information. It's also not advised to treat multiple lesions in the same area because you can cause too much inflammation. And they talked about treating mosaic warts in sort of sections if you had a larger wart. They debrided the lesion with an 11 or 15 blade to remove that superficial keratin debris. And then they also did a very important step that most of us don't do, where they had the patient come back 24 to 48 hours later, and they actually removed all of the blister roof. And I think that in the US, we tend to tell people to leave the blister intact. I've always wondered if that's leaving viable virus potentially in the epidermis, which could then sit back down and reinfect the skin. I actually want to think about a study where you would take that removed skin and maybe put it on like a nude mouse or something and see if you can inoculate virus from the shed skin of a blister after it's been treated with cantharidin or something like that. But I think that this is a very nice treatment protocol. After that, they let the patient heal for 15 days, and if they need reapplication, then they would reapply it at that point. So important things to bring out of this article, I think, the fact that there is some risk to specifically the kidneys with accidental ingestion. I'm always very careful about using cantharidin in children that are too young to know not to put things in their mouth. Because you have to be very thoughtful about the possibility that they could accidentally get a systemic dose. It's also not recommended to use this topical preparation in pregnant or lactating women. But otherwise, it had a great safety protocol with a very efficacious kind of track record in terms of complete resolution with often just one treatment. So I'm kind of dying to try this now. I have a great compounding pharmacist here in town that I plan to sick on this pretty soon.
Shockingly good results.
Mm-hmm.
Too good to be true, question mark? So what's different about this than what we already do? They have people come back afterward to, like, I guess use scissors and forceps to snip off the blister roof and take it off. And I was thinking, man, this compounded stuff seems kind of cool. I assume it's the specific formulation. But then while you were talking, I thought to myself, okay, I know I've got cantharidin in our clinic, and I don't think it's all that great. I usually kind of use it when kids won't tolerate cryo or anything else that's kind of uncomfortable, like Candida. And the brand that we have is Cantharone, and it comes in two varieties, something just called Cantharone and something called Cantharone Plus. And I was like, I know Cantharone Plus is like got salicylic acid and stuff in it. So while you were talking, I looked it up, and it's actually this stuff. It's cantharidin, podophyllotoxin, and salicylic acid. The strength of the podophyllotoxin is not as much, though. It's 2% rather than 5%, which was what was used in this study. But everything else is the same percentages. And I'm unimpressed with cantharidin Plus. So what's the deal? Is it actually the extra podophyllotoxin that's making the difference? Is it these patients coming back a day or two later? What's the story?
I actually really wonder about that patient coming back step and the, in-office debridement of the blister roof. This has raised a lot of questions for me that I want to look into because I'm very interested to figure this out. I think we may be limited with podophyllin in the US because the CDC recommends less than 0.5 milliliters, but I'm not sure if that's why that's the top concentration. So when I try to get this done with a compounding pharmacist, I'll find out if there's something we run up into.
Well, it's interesting, and especially the review that I discussed had 5 studies with 250 patients that looked at this cantharidin, podophyllotoxin, salicylic acid stuff, not just this one, and they
Mhm.
got great results. So interesting. Maybe I'll just stick with cantharidin plus, but have patients come back. I don't know.
It's an
It's hard to fit
interesting
them into the
question.
schedule and stuff.
Yeah, that is a hard thing to fit. Metaphorical food for thought, but don't actually eat it so you don't give yourself acute nephritis and potentially die.
Yeah, I don't know what I'm going to do with this information, but it's interesting that some people have got such good results. Moving on to something completely different. I'm so happy about this next study. So it's out of the JAD, and it's called Central Nervous System Magnetic Resonance Imaging Abnormalities and Neurologic Outcomes in Pediatric Patients with Congenital Nevi, a 10-year multi-institutional retrospective study. First author is Holly Neal. Senior author is Elena Hallruluk. Sorry if I mispronounced your name. So, Michelle, you might remember that back in episode 70, we discussed an article that I said has given me the most angst out of any article that I have ever read about the congenital melanocytic nevus syndrome,
Mhm.
which that phrase or term that article introduced, and stated that based on their data, babies born with 2 or more nevi of any size anywhere in the body should get an MRI, ideally before 6 months of age. And the reason is because risk of CNS abnormalities increases with increasing size and numbers of lesions. So I'm sorry, the idea is that congenital melanocytic nevi are usually due to a mutation in NRAS. And if you just have one congenital melanocytic nevus, well, probably you just have an NRAS mutation in the tissue right there. But if you've got 2, then perhaps an NRAS mutation started early enough in fetal development that it could affect other things. And the thing it tends to affect is the CNS. So in their study, they got MRIs of the CNS on a lot of children, and a surprising number of them had abnormalities. And they do say that the risk of CNS abnormalities increases with increasing size and numbers of congenital nevi, but based on that study, which was 2015, the science was not yet refined enough to say, well, if you just have 2 small nevi, the risk is really low, so don't bother. So this idea was like 2 3-millimeter nevi, based on the literature we had at the time, they should still get MRIs, which just somehow didn't seem right. But hey, sometimes science doesn't seem right, but it's still science. Science is real, people. So, good news, this retrospective study that we're discussing today aims to address that knowledge gap. And I'll tell you that the outcome is good. So, it's a review from several different hospitals in Massachusetts, Mass Gen, Boston Children's Hospital, and the University of Massachusetts, that looked at 352 children with congenital melanocytic nevi of any size who got an MRI of the CNS for any reason. 46 of them, 13%, was because somebody was worried about their congenital melanocytic nevi. All of the other kids got an MRI, for some other reason. They had a sports injury, for example, and they also happened to have some congenital nevi. So 12 of the patients, 3% of the total group, had concerning findings, and all of those patients were in the I'm worried about their congenital nevi group. So it was 26% of that particular group. And the findings overall are very reassuring for patients who have multiple small nevi, which are the patients that cause me the most angst. So, specifics. There were 15 patients with multiple small congenital nevi, and none of them had concerning findings. Hooray! 0.
Woo!
Of the 12 concerning MRIs, 8 of them showed melanin in the CNS. And as we discussed in that last article, that's not necessarily a bad thing. I mean, I guess you would rather not have melanin in your CNS, but it can just sit there and not do anything forever, or it can do stuff that's of questionable concern, or it can do stuff that's bad. All of those patients with the melanin in their CNS had 4 or more congenital nevi, and the largest was medium in 2 patients, or giant in 6 of them. And one of those patients developed fatal CNS melanoma. So that's probably the old school neurocutaneous melanosis that the textbooks used to say was a death sentence. But as we discussed in that previous article, not a death sentence, sadly for that one patient it was, but not for, I would say, the majority of people who are found to have melanin in their CNS. The other 4 of the 12 concerning MRIs showed other issues. And again, as we discussed in that last article, other stuff that's wrong in the CNS is highly variable, and patients need to be treated just on an individual basis based on what exactly you find wrong in the CNS. In this particular study, there was prominent vasculature in one patient, a Chiari-1 malformation plus syringomyelia in one, tethered spinal cord in one, and a venous malformation in one. The patient with a tethered spinal cord, this one is kind of interesting, had only a single congenital melanocytic nevus, which is kind of scary. It was medium on the left upper back, so not even near where your cord would get tethered, but also had a sacral dimple. So perhaps the nevus was a red herring or hypermelanocytic herring, and it was the sacral dimple that was really what was going on, and you could pick that up with ultrasound if you get it early enough without necessarily needing an MRI. 4 of the patients with concerning MRIs required neurosurgery. And aside from that one tethered cord patient that I mentioned, all of the patients with only a single congenital nevus had unconcerning MRIs, including 10 with medium nevi and 4 with large or greater. So again, supporting this idea that it's really multiple and not just like one big one that's the problem. The kids with concerning MRIs were more likely to have seizures than kids who didn't have concerning MRIs, 33% versus 9%. And more likely to have neurodevelopmental problems than kids without concerning MRIs at 58% versus 24%. And, these sort of, quote, matched controls, the kids who just happened to have congenital nevi and also got CNS imaging, I guess they're not really controls because they had CNS imaging for some reason. So that probably explains their, what I assume is a higher risk of neurodevelopmental problems. 24%. I'm hoping it's not 24% in the general population. So these authors conclude that medium or larger congenital nevi, plus at least one other nevus of any side, should prompt imaging. And they say, we propose healthy asymptomatic children with few small congenital melanocytic nevi or a singular congenital melanocytic nevus of any size do not require MRI screening. Hooray!
Woo!
Don't need to feel anxious about it anymore. So as a reminder of the sizes, so these are somewhat arbitrarily divided into small, medium, large, and giant. And this is projected adult size. So small congenital nevi are 0 to 1.5 centimeters. Medium is 1.5 to 20 centimeters, which is a huge range. Large is 20 to 40 centimeters, and giant is 40 or more centimeters. And if you're trying to figure out, okay, let's see, this is on this baby's cheek and it's 1 centimeter now. So is it count as small or is it actually medium? Because their head's going to grow and stuff. There's apparently pre-established enlargement factors for neonates. So you want to multiply the size by 1.7 if it is on the head. So the one I just mentioned would actually end up being 1.7 centimeters and would count as medium. You want to multiply it by 2.8 on the neck, trunk, arms, and buttocks. And you want to multiply it by 3.3 for the legs. Those are specifically for neonates. If the kid is 5 years old, then good luck figuring it out. So very happy with these results. Thank you, authors. I'm kind of interested to see what that group out of Britain who published that original article thinks about this. I imagine they support it as well. It's kind of what the pediatric dermatology community suspects, that, 2 small congenital nevi probably are not worth an MRI. So thank you. Thanks, guys, for doing this. It puts my mind at ease, and I suspect it will put some of my patients' parents at ease as well.
Awesome. Well, speaking of putting people at ease, we're going to discuss a TYK inhibitor, a tyrosine kinase inhibitor called Deucravacitinib, and largely the findings of this trial are relatively reassuring. So this is a long walk to make a connection between these two articles. Probably not going to get... Oh, there is a genetic syndrome I'll talk about, so we'll go there. All right.
Okay, great.
Yes.
You seem to care more about transitions than I do. I just okay, let's just talk about something else now. And you make the effort, Michelle. That's why we appreciate you and your neurons. They're firing.
We could at least say now for something completely different. So this is an article out of the JAD 2022 by one of my favorite dermatologist in the whole world, April Armstrong, who's just amazing. I got to meet her in person at Fall Clinical recently, and she is just such a lovely human being and a great dermatologist and representative of our specialties. So
She's probably we haven't looked into it, sorry to interrupt, but she probably also gets the award for like most dermosphered author.
I think she probably would, yes. She's quite prolific in her publications. So she's the chief author, and then the corresponding author is Andrew Blauvelt. And this work was published in the JAD 2022. Importantly, it is sponsored by Bristol Myers Squibb, who makes Deucravacitinib. The trade name for Deucravacitinib is Sotyktu. When I first saw that word written out, I was very irritated with it. I was like, why did they put so many consonants back together in this word? But then I realized that it's spelling out what it does. It's a TYK2 inhibitor. So it's a tyrosine kinase 2 inhibitor. So that actually is a helpful drug name. It helps you remember what the drug does. The purpose of the study is to compare the efficacy and safety of Deucravacitinib or Sotyktu, which is an oral selective allosteric tyrosine kinase 2 inhibitor.
What does it mean to be allosteric?
It's binding, but not to the active site, is what I believe that means. But I shall have to confirm that. So
I'll go on an info
it's a
quest
regulatory.
for you, Michelle.
Thank you. Please do an info quest. That's something I have residents do sometimes when they ask a question I don't know the answer to yet, or that I may have forgotten with all of the copious amounts of things we deal with in the day to day. And so they go on an info quest. It sounds so much more fun than go look it up, right? So they did the study, so Sotyktu up against apremilast and placebo. In this study, which they called Poetic, which is cute. It's a 52-week double-blind phase 3 study. The two co-primary endpoints were a PASI 75 and a static physician's global assessment score of 0 or 1, which corresponds to clear or almost clear. At week 16, they had significantly higher responses in the Deucravacitinib arm versus placebo or apremilast. So Deucravacitinib had 58% of their patients reach PASI 75 versus apremilast, which was 35%, got to PASI 75 versus placebo, which was 12.7%, got to PASI 75.
And PASI 75 roughly means your psoriasis is 75% better.
Awesome. For the comparison of the physician's global assessment being clear or almost clear, they also saw improved results for the Deucravacitinib versus the placebo and versus the apremilast. So for the physician's global assessment, 53.6% of patients on Deucravacitinib got to clear or almost clear versus 32% on apremilast and 7.2% on placebo. So it looks like it does have better efficacy than some of the other orally available agents to treat psoriasis. Tyrosine kinase 2, TYK2, mediates signaling through interleukin 23, as well as interleukin 12, interleukin 10, IL-22 and IL-6, and the type 1 interferons, interferon alpha and beta. So it's an important molecule in transmitting a lot of signals through the cells that can contribute to the formation of psoriasis or other inflammatory conditions. There are individuals who have loss of function genetic polymorphisms of TYK2. These patients have a lower risk of developing psoriasis and other immune-mediated diseases. And the authors say without substantial safety concerns, and that's technically true. I did look up to see what patients with TYK2 mutations are more subject to, and they are at greater risk for intracellular infections specifically and viral infections. So the first patient with a TYK2 mutation was presented in the literature in 2006. It was an Asian gentleman who was 22 years old, who had a TYK2 deficiency, autosomal recessively inherited, who also had hyper IgE syndrome. Since that time, many more patients that have a TYK2 deficiency have been described, not all of them associated with hyper IgE, but there is a potential increased risk for intracellular bacteria such as Mycobacterium, Salmonella, Brucella, and viral infections such as herpes virus. So things to keep in mind as these medications might be used more broadly. TYK2 is an attractive target for psoriatic therapeutics because of this. So Deucravacitinib is a selective TYK2 inhibitor, and it is being looked at for the treatment of things like plaque psoriasis and psoriatic arthritis, inflammatory bowel disease, and systemic lupus.
And it's approved.
Yes. So go ahead.
I was just going to say, one reason I wanted to talk about this is because I feel like there's new drugs being approved all the time for dermatology, and I was surprised to discover that Deucravacitinib or Sotyktu has been approved of October of 2022. So I think important always to talk about the trials that got things approved so we can decide whether we want to use it or not.
And excitingly, I was right about allosteric. So in biochemistry, allosteric regulation is the regulation of an enzyme by binding an effector molecule to a site that is not its active site. So yay! Because that was very old memory that I was dragging forward from my undergraduate cell and molecular biology degree. So this is a selective TYK2 inhibitor that is allosteric. So this particular medication does not bind at the active site, it binds at a regulatory site. And it's able to affect the expression of cytokines that would typically be triggered through its pathways. It had superior efficacy and very good tolerability. So we'll go into that a little bit. We talked about their co-primary endpoints. There was data collected for patient-reported symptoms, as well as quality of life and adverse events. So this kind of data was collected for all of the treatment arms. The adverse event rates were similar across all three, but you can predict the kinds of side effects that occurred in the different groups. So for deucravacitinib, the most common side effects were nasopharyngitis and upper respiratory tract infection. Not a huge surprise, potentially some viral vulnerability there, although there is good documentation that there was not an increased risk for poor outcome or infection from SARS-CoV-2 or COVID-19. So that's reassuring. Apremilast, as you would expect, had side effects of headache, diarrhea, and nausea. Not a big surprise there. Surprisingly, the placebo arm had the most side effects, which was interesting. So they had a little bit more, I think, activity of side effect over the weeks 0 to 16 in the placebo group. So it was actually lowest side effect rate in the deucravacitinib group, 2.1% versus 5.5% with placebo and 2.4% with apremilast. There was also one death in this study, which occurred in the placebo group. I felt bad for being relieved that the death was in the placebo group when I was reading this, because a person still passed away, and that's very sad. But sometimes I do feel like random death events may happen in some of these trials and may put a sort of cast a pall over a medication that maybe doesn't deserve it. So I was grateful that didn't cloud the analysis of this data. I am
It
sorry
looks
that that
like
person passed away.
yes, it looks like psoriasis is listed as an adverse event, so maybe that's like worsening of your psoriasis.
Okay, so maybe that's why placebo had the higher event rate.
I wonder.
They also had pericarditis and cholecystitis that were reported in 2 deucravacitinib treated patients, so something to kind of pay attention for if we start to see a signal for that. Discontinuations due to adverse events were lower with deucravacitinib than placebo. Again, that may be related to efficacy, right? So if you're on a treatment that's working, you may be more likely to tolerate things than if you're on a treatment that isn't doing much. And then they had the one death in the placebo group. No clinically meaningful changes from baseline. Laboratories were observed in any of the patients through week 16. Of course, the one that you might expect to see in a patient with TYK2 inhibition, if it's kind of along the same pathways which you see with the Janus kinase ones, would maybe be hypercholesterolemia, but they didn't see anything like that. Let's see. So they saw an increase of response through week 24 with the deucravacitinib arm. And they also noted that the patients had greater improvement in things such as scalp psoriasis and psoriatic symptoms on the deucravacitinib treated arm. The increased rate of viral infections, including herpes zoster, had been documented in patients given other immunomodulatory agents. So they kind of list some of those. In this study, herpes zoster infections occurred at a low rate in the deucravacitinib arm. So they had 1.2 cases per 100 person years in the deucravacitinib treated arm. All the cases were mild, localized, and followed a benign clinical course. None of them led to discontinuation.
So as we discussed in a previous article, new CDC guidelines are give people the shingles vaccine if you're going to immunosuppress them, as long as they're an adult, but of any age. So JAK inhibition seems good enough. So I would always recommend that my patients would get the shingles vaccine first dose before you start the medicine, and then the second dose, afterward is probably fine.
They do note that the trial is limited by a 1-year duration. This is a chronic condition that might require lifelong treatment. So they note that longer term analyses are appropriate and prudent to do. Racial diversity was limited. Greater than 98% of the patients self-reported as white or Asian. So generalizability may need to be looked at as well. But they found that deucravacitinib was well tolerated. It was superior to placebo and apremilast. It didn't elicit any changes in laboratories that were characteristic of JAK 1, 2, and 3 inhibitors. And the once daily dosage may be improving on patient compliance and adherence to therapy. So I think a lot of good information about this novel therapeutic. The oral medications for psoriasis versus the injectables, there's sort of a different playing field that you're dealing with, and it's different patient populations generally as well. There are some patients that are just very uncomfortable with anything injected and are very happy to use a medicine that works well but isn't a showstopper if they don't have to have an injection. I think that there are other patients that don't mind having a shot and then not thinking about it for a period of time. And so, of course, treating the individual in front of you is part of the art of medicine. What do you think, Luke?
Well, I was going to say, if this were 15 years ago, I'd be pretty impressed. But in the age of biologics for psoriasis, it's actually not that impressive compared to all the things that we have. And it beat a Premolast, but this is a classic case of showing your new fancy drug can beat the crappiest thing out there. Because
Hey, I like a Premolast. It has a lot of places where it's very useful.
I meant literally crappy. People get diarrhea on it.
Bum.
No, but it's, of all the approved things for psoriasis, it's like, now, I guess now there's Deucravacitinib, but it's the only like orally approved thing. You can't really compare this to methotrexate, right? Because it's not FDA approved. But Premolast just has unimpressed me anyways. And if you compare Deucravacitinib to the biologics, it's no question the biologics are more effective. So, for example, Deucravacitinib in this study had a PASI 75 of 58%, whereas the top biologics have PASI 90s of around 70%. So they're way more effective, and a lot of them are shots like every 2 months. So would you rather take a pill every day or a shot every 2 months? As you say, there's some people who would prefer a pill every day, but I feel like honestly most people would prefer the shot every 2 months. Also, let's talk about cost. So Sotyktu apparently is about $6,200 a month, which is about $74,000 a year, which is kind of roughly the same as the biologics. It's actually a little bit more expensive compared to risankizumab, brodalumab, and guselkumab, which are the top performing ones based on previous studies. But still, I would say it's fairly comparable, and they vacillate all the time. So you're not really saving on cost by prescribing somebody Deucravacitinib either. So I think it's like you say, if the patient really just wants an oral medicine that works pretty decently well and doesn't have a lot of side effects, this is a pretty good one. And that's fairly high praise, works decently well, not a lot of side effects. Just in the age of psoriasis biologics, we've got really other great options.
Yeah, for me, it kind of sits where Enbrel is. And actually, if I was looking back at the original studies on Enbrel, and they got to about 50% of their patients got a PASI 75 in 12 weeks with the Enbrel twice weekly dosing. And I remember being a medical student, and Dr. Palger, who's a dermatologist in Lubbock, in beautiful sunny Lubbock, Texas, who is very generous with his time with medical students, was allowing me and some other students to rotate with his clinic, and got so excited talking to me about the new biologics that they were making for psoriasis and what an exciting time it was to be a dermatologist. And what's really kind of cool to think back on is that was sort of the beginning of my career as a dermatologist, was that rotation, because that's really where I fell in love with the specialty. And how far we've come since that time, where a 50% PASI 75 was groundbreaking at that time, and now we're looking at PASI 100s.
Right, now we sneer at it.
So, the game of treating psoriasis has changed so much in the past, decade and a half. It's been a kind of big sea change in how we treat this condition. And I think that what we've learned is that not only is the disease very, very heterogeneic, I think in the future, eventually we'll have IL-17 psoriasis and IL-23 psoriasis, and we'll pick the biologics that are appropriate for the patient based off of the cytokine profile of the condition. But, I also think that we have different types of psoriasis patients. We have the ones that are sort of the better living through chemistry people, and then we have our crunchy granola patients, and we have everyone in between. It's nice to have a different option to offer some of these patients, and also we maybe understand a little bit more pathomechanistically about why the condition occurs and does what it does.
I want to close with just one other really quick article that was brought to my attention at the Society or the Texas Dermatology meeting that you and I were at. Dr. Chad Hausman, a Mohs surgeon, gave a really nice talk, and he cited this particular article, which is from 2016. It's just like one paragraph, like surgical pearl in the JAD. It's called Intraoperative Retention Sutures to Facilitate Closure. The authors are Lawrence Feigenbaum and Rajiv Nijawan. Sorry if I mispronounced your name. So basically, if you put in a couple stitches between Mohs stages while you're processing the tissue, it can facilitate later repair due to what they call tissue creep. I don't do Mohs surgery. I have colleagues that do, but I learned it in residency. So you make a hole and then you go and process the tissue for like 45 minutes. And apparently, if you put a couple stitches in that hole while you're working, you end up with better repairs or easier repairs or something. They say it's especially helpful in large or high tension wounds. They usually put in just a couple simple interrupteds just to pull the tissue closed a little bit, or they put in a pulley stitch. They say close it in the direction where you want to repair it, like the relaxed skin tension lines, and then they cite a few of their cases, like 5, where they felt that it improved the ability to use a more simple closure rather than a big flap or something like that. And there's some good pictures in here as well. So if you're a Mohs surgeon and you're not putting in stitches in between stages, maybe consider it.
I like it. I like it a lot.
Okay, that is all for today. Thanks, guys, for joining us. And thanks, of course, to Eleonora for joining us to talk about Derm in space. And thanks to our other medical students who help with various things on the podcast. Really appreciate you guys. Our team, in addition to Eleonora, includes Morgan Dykman, Guy Kusecki, Michael Birdsall, Aparna Nayak, Neha Deho. Thanks also to our institutions. Thanks to the University of Utah for supporting the podcast, and thanks to Texas Tech for lending us Michelle. If you would like to find more of us, I can hardly blame you. You can find our entire archives on our website, dermospherepodcast.com. It has links to all the original articles as well. You can also find us on social media. We are on Facebook, Instagram, and Twitter. We'll put all those links in the show notes. And I also wanted to tell you guys that if you want to hang out with me sometimes and some of the other University of Utah derm faculty, we have started a dermatology echo. Michelle, you're familiar with these echoes, right?
I am familiar with echoes. Those are cool.
So an echo is like every month you hang out over the lunch hour, you have like a brief 15-minute didactic about something. I gave one on warts and molluscum, and then you bring your own like difficult cases and talk about it. It's all, virtual. You get CME credit out of it. It's free. So if you want to go to ours, you can find we'll put the link in the show notes, but we're physicians.utah.edu/echo/dermatology-primary-care. It's sort of intended for primary care folks. But anybody is welcome for sure. Also, all of you guys out there, we would love to see you in Hawaii in February. And we'd love to see you on our other podcast, which is on a little bit of a break right now, but the episodes are still out there, and we hope to be revamping it one of these days when the time is right.
The other podcast is called SkinCast. It is directed at the lay public. It's about 15 to 20 minutes per episode, and it covers typically a single topic or a small group of topics at a layperson's level. We've covered things from contact dermatitis to acne to psoriasis to sun protection to skincare regimens to hair loss. And they're kind of directed at that sort of layperson level where SkinCast has its own distribution and is available on all of the podcasting platforms.
That's right. So we'll see you over there as well, and we'll see you back here in 2 weeks.